ask our first presenter, Professor Rachel Murray, and she will be presenting her abstract, Personalized Smoking Cessation Support in Lung Cancer Screening Program, the Yorkshire Enhanced Stop Smoking Study, also known as YES. And I will give a little bit more background on her before she comes up. So she is a professor who specializes in tobacco control research in multiple health settings. She's currently the PI of the Yorkshire Enhanced Stop Smoking Study, yes, which is what the title is, which is the subject of her presentation today. She joined the University of Nottingham in March of 2004 as a research associate, completed her PhD in 2009, was appointed as a lecturer in the health policy and promotion starting in August of 2009, and then achieved a master's degree, promoted to adjunct professor, and then to full professor in August of 2020. So, welcome.
Thank you, Heather. So yeah, it's fantastic that stop smoking intervention has got the kind of coverage at this conference in a presidential symposium, and I'm delighted to talk about it with you today. So yeah, I will refer to it as the YES study, but it's a study that looked at adding co-located and personalised stop smoking support to a lung cancer screening programme in Yorkshire. So smoking is the biggest contributor to lung cancer, and smoking cessation is the most effective way that we can reduce lung cancer mortality. But what we do find is people attending for lung cancer screening, probably only around 2% of people will get a lung cancer diagnosed through the screening programme. But what we do have is around 30% of people who have a treatable condition in the form of tobacco dependence, and this is a really fantastic opportunity that we can capitalise on that. And some modelling work in the US has calculated that adding a tobacco control intervention to lung cancer screening will decrease overall deaths by an additional 14% and increase the overall number of life years gained by 81%. So there's fantastic gains to be made. And what we also know is that lung cancer screening in itself might provide what we call a teachable moment. And a teachable moment means that someone is motivated to make a positive behaviour change in response to something else. So in this case, attending for lung cancer screening may motivate people to try and change their smoking behaviour and make a quit attempt. And the research has also shown that attending a lung cancer screening is in itself a motivator. So just going for that initial appointment. So the ingredients are already there for a really successful outcome. And the research is growing, but what there isn't currently is a consensus on how best to integrate stop smoking provision within lung cancer screening, be that in the United States, the United Kingdom, or anywhere else around the world. What we know from elsewhere is that using effective stop smoking support makes it 4 times more likely that people will quit successfully. And there's some growing suggestion and evidence that there might be a potential to use real personalised intervention in the form of lung and heart images that are collected during lung cancer screening as part of the toolkit, if you like, to help people quit more successfully. So that's what our study was set up to look at, so the YES study. And it's nested within the Yorkshire Lung Screening Trial in the UK, which is similar to the lung cancer screening programmes that are held in other places. In this case, anyone that was a smoker that attended for lung cancer screening was offered an immediate consultation with a smoking cessation practitioner, or an SCP that I'll probably refer to them through the rest of the talk. That was on an opt-out basis, so unless people specifically said, no, I don't want to see them, they would go through that doorway on their clinical pathway. And within that session, they would get behavioural support on a one-to-one basis with an SCP, and they would also be provided with pharmacotherapy, so maybe nicotine replacement therapy, or referred to their GP for Champix or bupropion. And we also offered e-cigarettes as part of our package of intervention. At this point, we talked about the YES trial, but we didn't do anything further, and people went away with the consent form. So for the first 4 weeks, everybody got the exact same treatment of this counselling and behavioural support and pharmacotherapy. When we saw people for the 4-week follow-up point, which is a standard measure, we'd collect their smoking status to see if anyone had already quit, and we used some exhaled breath carbon monoxide as a validation. And then people were consented to take part in the study, and if they consented, they went to either the control arm or the intervention arm. Control arm got exactly the same as they'd had already for another 8 weeks, so totaling 12 weeks. And our intervention group got the same as the control group, but they also got this personalised intervention, which was their own heart and their own lung images, which I'll show you in a minute, plus some supportive scripted communication from the SCP. We followed these people up at 3 months and 12 months, and we collected smoking status again, some psychological change variables, quality of life measures, and their healthcare usage. So this was our participant flow. So really briefly, 2,248 people who attended for lung cancer screening were smokers, and that's about a third of the overall lung screen population. 2,150 were eligible for a referral to the SCP, of which 89% were seen on the mobile unit at the time of their appointment, and 84% agreed to receive ongoing support. If we look at the proportion of those who did agree to the ongoing support, we looked at 7-day validated point prevalent abstinence. So these are people that said they were quit and had been quit for 7 days at the 4-week period, and 16.5% were validated as quitters, and that increased to 20% if we used self-report, so people telling us that they'd quit but we couldn't validate it for whatever reason. And that gave us a cost per validated quitter of just under £415. But then it's all well and good the people who are really motivated, but this is a whole service level. So if we look at everyone who would have been eligible for the intervention, our validated quit rate was 12.4% at 4 weeks, increasing to 15% on that self-reported measure, with a cost for validated quitter of £523. So of this, 1,003 people consented to take part in the study, and they were randomised at the point they agreed to see our advisor. So we ended up with 476 people in our control arm and 527 in our intervention arm. Briefly, this is what individuals were shown as part of the personalised intervention. So on the left is an example of a heart image that we showed people. So the left-hand image is their own heart collected from the CT scan, and the white area is coronary artery calcification, which is part of heart disease. Now, that was really unintelligible to most of our participants. So what we did was we translated to an artist's impression of a heart, which is that middle image, and then the white highlighted areas have been coloured in yellow to translate to our participants what they were looking at. Similarly, on the right-hand side, this was an example of a lung page. So the first image, we would highlight areas of emphysema from individuals' own scans. And then in the middle image, where possible, we attempted to get an area of healthy lung. So what we were telling people is they have been damaged to your lungs, as seen in this first picture, but there's still healthy areas of your lung that you can preserve in the second picture. Briefly go through, these were our participant demographics. So we had an equal split of males and females. The majority of our participants were from the most deprived group, as you can see in the second row. And we used something called the Fagerstrom test of nicotine dependence to measure dependence levels, and a third of our participants were in the least dependent category. Not unusually, most of our participants had a negative scan outcome, so their CT scan as part of the lung cancer screening was clear, there were no concerns. And about half of our participants said that they were really extremely or moderately confident that they would be able to quit smoking successfully. So there was no difference between our study arms on any of these factors. So the primary outcome of the study was 7-day validated point prevalent abstinence at 3 months after the lung health check. And as you can see here, we had 33.6% of our study participants who were validated as abstinent at this point, with a cost per quitter of £521.30. And translated across the usual care, we had a 30% quit rate with a cost per quitter of £412.80. Secondary outcomes are listed below in terms of quit rates, so self-reported at 3 months and then validated and self-reported at 12 months. There's no significant difference at all between any of the study arms, but what was really promising is that our 12-month quit rates were around the 30% mark, and if people have quit for 12 months, that's a really, really good sign that they're going to be quit long-term. So the fact that it's remained at 30%, and they normally drop off as well as time goes on, so that was really positive. We looked in a bit more detail at our primary outcome, and what we found is there's significant interaction around sex, in that females were significantly more likely to quit smoking in our intervention arm than in the usual care arm, and they were also less likely to quit than their male counterparts in the usual care group. There was an interaction around deprivation level, with all deprivation groups being more likely to quit in the intervention group, apart from our second least deprived, which had quite a sizable difference in the opposite direction, which is why we've not seen any significant effects in there, we think. And not surprisingly, those people who'd had a positive or an indeterminate scan, so something was wrong on their scan that they had as part of the lung cancer screening, they were more likely to quit as well. There was no difference according to the age of our participants or the pharmacotherapy or vaping supplies that they'd chosen to use. And very similar results were found at 12 months. We still have this significant effect of gender happening. There was an interaction around pharmacotherapy, but no real clear pattern about a strong winner or loser in that sense. And there was no effect anymore of age deprivation or the scan outcome. The other thing we looked at is the content of those booklets that I just showed you. So at 3 months and 12 months, people that had a normal heart scan, so not showing any evidence of heart disease, were more likely to quit than those that had seen any image showing heart disease. And those with normal lung images were less likely to quit than those people that were showing any signs of emphysema. So we've also conducted a process evaluation alongside the YES study, which is being led by the University of Cardiff. Cardiff University. And what we found that the provision of a co-located and ongoing stop smoking support with real compassionate care was really well received by our participants and was key to sustaining that quit attempt. Having the drop-in phone calls on a regular basis was really important, and I think that became even more important through COVID, where a lot of our participants were more socially isolated than they would have been before. And everything was there on the doorstep for them when they went. They didn't have to go anywhere else to see a practitioner. They didn't have to go anywhere else to pick up their quit supplies. They also liked the fact that it was very holistic and compassionate, the care they received. There was no judgment. A lot of times if you talk about smoking and lung cancer, there is a big stigma and a blame culture around that, and that's something we tried really hard to avoid, as does everybody that works in this field. And I think the final thing, the result we got wasn't what we were expecting, I think. We were all optimistic that showing these heart and lung images would be really important. But I think when it came down to it, our intervention effect was diluted by how good the support the participants received in that first 4 weeks with the gold standard that they'd got. And actually people had moved along that journey by the time they received the booklet at 4 weeks. So just in conclusion, having stop smoking intervention as part of the lung health check in a real integrated manner was positively received by both participants, patients and staff. Having the physical presence and being convenient was a key strength, and also the fact that we delivered a high intensity intervention. These participants, they've got long smoking histories, they've often got a lot of other things going on in their lives. And so a brief intervention or a light touch is unlikely to have been effective. The individuals may not be ready to quit at the point they attend for lung health screening. So our quit rates went up between 4 weeks and 3 months, which is a really unusual finding. But people are coming to lung health checks, they've got other things on their mind, they're concerned about what their lung scan is going to show. But having an ongoing support offered is really important, and we can pick people up at other points on the journey. It was really positive that around a third of our participants were quit at 3 months, and that was largely sustained. As I've said, that's a really good indicator that this is a long-term behaviour change and not a short-term reaction to the lung health check and the lung cancer screening. Our quit rates are higher in those with abnormal scans, so it's really important to be working with these people who have got abnormal scans coming through to help them change their behaviours. And as you've seen, our intervention may be effective in females, and I think there's still some questions around that about whether it's generalisable, why we found the findings that we found. But I think the one question that we don't have is that co-locating and doing an evidence-based gold standard stop smoking support within a lung cancer screening setting is just vital. It improves the cost effectiveness of screening. It's receiving, really good feedback from the people that take part, because some people think it's going to put people off attending. It hasn't done that. We've got good quit rates, but that needs to be a real holistic and high intensity intervention. And these just the acknowledgements. The acknowledgements are our co-investigators, particularly Matt Callister, who's the clinical lead on the study. And then on the right, these are the true heroes. These are the smoking cessation practitioners who are doing this day in, day out. And I don't know what they do with the people who set foot in the room that swear they're not going to quit smoking, come out with all their pharmacotherapies, and then go on to quit. So these guys are doing an amazing job, and it's all about them. Thank you very much. Great.